Dr. Ronnie Sass has presented a talk regarding the treatment of acid reflux disease to a Medscape audience. I would like to present a summary of that talk. Dr. Sass described the definition for gastroesophageal reflux disease. He indicated that it could be defined as reflux symptoms caused by intraesophageal acid without any visible evidence of mucosal damage at endoscopy. Most patients with non-erosive esophagitis do not progress to erosive esophagitis or Barrett's esophagus. Patients with non-erosive esophagitis versus those with erosive esophagitis tend to be female, leaner, have a shorter duration of symptoms, and hiatal hernia is relatively uncommon. So, we can decide if patients have GERD based on their history. If they present with heartburn or acid regurgitation, that suggests they might have GERD. But a better diagnostic modality is initiating empiric therapy for these patients with anti-secretory medication. If there is a response to therapy, that tells us that these patients have GERD. Other diagnostic modalities are more invasive. Endoscopy may be helpful in diagnosing GERD, but its sensitivity is limited. 24-hour esophageal monitoring for pH is often used to evaluate patients who fail proton pump inhibitor therapy. The suggestion was made that if the patient is older than 50 and they've had GERD symptoms for at least 5 years, that an upper endoscopy should be considered to rule out Barrett's esophagus. Who are the patients that fail PPI? PPI failure may occur in patients with Barrett's esophagus, erosive esophagitis, or non-erosive esophagitis. Studies have shown that they primarily come from the non-erosive reflux disease group. Non-erosive reflux disease, or symptomatic GERD, is the most common group amongst those with GERD. Within this group is a subgroup of patients that are called functional heartburn. These are the patients who have normal pH in addition to the fact that they have normal endoscopy. These patients with functional heartburn come from the group of patients with non-erosive reflux disease who have the lowest PPI response rate, and most of the patients that compose the PPI failure group are from this functional heartburn group. Symptoms are the most important therapeutic concern for patients with non-erosive reflux disease. The goals also include to prevent symptom relapse and to improve patients' health-related quality of life. The last thing mentioned in the Medscape talk, which given the potential side effects of long-term PPIs, seems controversial and was stated to be to significantly reduce the patient's reliance on other anti-reflux modalities, mostly over-the-counter drugs. Maintenance therapy up to 5 years for those with erosive gastritis is current practice. Erosions are healed with this method of treatment. Thank you.